Hello, everyone. Thank you so much for coming today. Welcome to our monthly webinar. And today we're going to be covering medical ethics with Dr. Mohsin Mohammed. So just to get started briefly, can everyone hear me okay?
Yes, we can hear you, Mohsin.
Okay, great, wonderful. Okay, so basically today we've decided to do it a little early. I know a lot of people are fasting, so it'll give you a chance to get off before iftar. So we're just going to do a quick welcome, and then we're just going to hand it over to Dr. Mohsin Mohammed, who's going to be talking about good medical practice and medical ethics, and we're going to have an open Q&A at the end. So what I want you guys to do is just really throughout the lecture, just get as creative as you want and start writing in questions in the Q&A. And what I'll be doing is I'll just be taking notes of them, and at the end, I'll just relay those questions to our guest presenter. Just before I do hand it over, I just want to give a big thank you to our sponsors, Lectorio. Lectorio is an all-in-one study resource for medical students, and it combines learning science and medical education into one easy-to-use platform. I personally use it myself. I love it. I think it's great, especially for people in younger years. They have like 3D anatomy stuff. People in older years, they have a lot of question cards, USMLE things, and all in all, it's just a lovely, lovely platform. So I'm going to hand it over to Dr. Mohsin Mohammed. Dr. Mohsin Mohammed is a graduate from Glasgow Medical University in medicine, and he has a strong interest in medical ethics and just such a familiarity to the system in the UK and how good medical practice is actually implemented. So I'm really excited to have him here today, and I feel like it's such an important topic for all of us to cover, despite whatever field we're hoping to get into. So I'm just going to hand it over.
All right. So my name is Mohsin Mohammed. So I'm doing FY1 in Edinburgh and Fife at the moment. Graduate from Glasgow last year. I really enjoyed studying there. I think it's a great university. And there was plenty of teaching in regards to ethics throughout medical school and in FY1. I think we've had 2 or 3 lectures from GMC already, and I think more will follow as our career continues here. And I've had personal contact with the GMC for a couple of things that went not the right way. In addition to that, there's always been issues in regards to patient safety and practice of medicine the right way on the wards. So I will try and share my stories as I present the guidelines from the GMC, and we'll also touch upon other things. So throughout, if somebody does have any questions, I would recommend that you write them down somewhere, keep them in your mind, and then you can ask them at the end of the lecture. So what we'll do is we'll quickly get started with this. So as I said, the main focus of this lecture will be GMC and what their guidelines are and how you can go about familiarizing yourself with them. We'll look at those. We will also quickly touch upon the tribunal. I'm not going to go too much into them, mainly because you don't really need to know what the purpose of the tribunal is. I mean, we've never had any introduction to them because you shouldn't be getting to that stage as a doctor, okay? You need to know they exist, and that's about it. Defense unions, that's very important. We'll cover those, and then I'll quickly go over some scenarios at the end as well. All right, so the 4 pillars of ethics. First of all, I'm pretty sure you've all come across these before starting medical school or during medical school. The first one being autonomy, and this is all about patients' autonomy to make their own decisions about their investigations and, more importantly, treatment. So and we'll cover what else sort of comes into autonomy later on in the lecture in regards to capacity, if a patient has capacity or not to make their own decisions, and how we can intervene as physicians if a person does not have capacity. Beneficence. So, we want to do the right thing. And I think if we can summarize this whole lecture in a couple of phrases, it would be do the right thing for the patient, and do the things in the best interest of the patient. And if you're doing that, you will be fine. Nothing will go wrong. And when you go beyond that, when you're not thinking in the best interest of the patient, that's when things go wrong. And that's where non-maleficence comes in, which basically means don't do harm. All right. And then finally, we've got justice, which is normally looking at the wider community and the use of your, for example, resources. And for example, here in the UK, we've got the NHS, which is a public entity, and realizing that if you're giving a treatment, it has a cost element to it, or if you're doing an investigation, it has a cost element to it, and you should be able to justify the use of that treatment or investigation, and does the patient really need it or not? And that kind of also comes back into beneficence and non-maleficence. For example, if you're using a CT scanner or a abdominal X-ray, you should be able to justify it because there's a lot of radiation associated with it. While we're on that topic, it's important to know, at least in Scotland, where I practice, I'm not sure about the rest of the UK. In Scotland, if you end up ordering an X-ray or any radiation-associated investigation for the wrong patient, or it's more about the wrong patient, then you will be pulled aside and questioned as to why that happened. That is associated with a DATEX form, and I will cover what a DATEX form is and how I had to fill one out later on. But I just wanted to highlight that radiation, it's an important thing to be aware of, and know that you can cause harm with it, and you should only be using radiation where it's needed, and shouldn't be willy-nilly going about doing chest X-rays, abdominal X-rays, and CT scans for the sake of doing them. You need to justify it. When you order up for the wrong patient, that's when you will be pulled aside to question. All right, so that's the basic pillars of medical ethics. Let me go on to the next slide. Oh, right. So next we'll cover, as I said, majority of the lecture will be GMC related. Right, so the purpose of the GMC, I remember this was actually part of my exam questions in first year of medical school, and it was like a 10-mark question. And if you put down these 5 main points, you would have gotten all 10 of those marks. So the GMC is one of the functions is to keep a medical register of all the doctors practicing under the GMC in the UK. And you guys will be added to that register if you decide to work in the UK. So as an FY1, I am on the provisional register, or I hold a provisional license, and that will be upgraded to a full license at the end of this year, which will be in about 3.5 months' time when I begin my FY2. All right, so that's a register, and that can be accessed by the public if they want to find out if their GP or consultant or registrar or FY1, FY2 is on the register or not. You can find me there as well if you go on the website. Standards for doctors. So this is where all these guidelines come in, and we will talk about one of the main tools that the GMC provides in the next slide, which is a good medical practice document. All right, so, and then education and training. As I said, I've had so many lectures from the GMC personally, directly from them, and then there is the universities that are governed by the GMC as to what they're delivering at universities. and further on training in postgraduate years. And then we've got revalidation. This is more to do with your postgraduate years and making sure that you are keeping up to date with training and education, and doing reflections on things that have gone wrong or have gone right, so that you can reflect on them and improve your practice for future years to come. Reflection is a very important part of your day-to-day practice, in fact, and in FY1 I think I have about 4 or 5 events that have occurred, one of them being the Datex one, where something did go wrong, and it's about reflecting on them. And my involvement, which I'll cover later in regards to the GMC, again, it involved a lot of reflecting on what had gone wrong. So reflection is a very important part. And if you start practicing reflection from medical school times at university, then it makes it a lot easier because you have practice. You practiced it already when you end up starting your job and continuing it. So and the final part of the GMC is concerns. So if the public or the team that you work with, if they have any concerns about your behavior or anything else, then they can raise that with the GMC. Or if you were to declare something to the GMC, then again, they can further investigate it. And they may just give you some advice. They may give you a warning, or they might actually put a restriction in place, which might be you cannot work for the next 6 months or 1 year, etc. They might ask you to retrain. And finally, if they want, they can pass you on to the tribunal service for them to make a decision about how they want to decide what should happen if the GMC is unable to make that decision, or they think that the tribunal would be a better place for this investigation to take place. So let's continue on to the good medical practice, because if you understand and you apply what is written in this document, then if we go back to the slide, you don't need to be worrying too much about the very last point that I just made. It's as simple as that. Having said that, you will read up on a lot of stories of just doctors being unlucky, wrong place, wrong time, or wrong patient in our case, that raise concerns to the GMC, and then there might be a suspension for you until that investigation is carried out. If you're a doctor, a practicing doctor, for example, there was a GP. There was a report he had written. A mother came in with a child. The child was 6 months or less than 1 year anyway, and the doctor decided to have a feel of the groin for lymph nodes, and the mother put in a complaint that the doctor has sexually assaulted the daughter, the less than 1 year old daughter. And this was investigated, and the GP had written this whole document, how it was hell for him, no income, and the stress of not knowing what's going to happen, and he was out of work for 9 months or so, and then it was only then he was allowed to come back in when they found that it was just a matter of the mother versus the doctor's word. There's no real evidence to show what actually happened. And the concern there was with regards to chaperone or not having a chaperone, and we'll cover this because that was a complex situation to be in, because normally we wouldn't expect a doctor to have a chaperone when examining a child, especially when their parents are there. But when a parent thinks otherwise, in regards to the sexual assault or something, that's when things can go wrong. So, that's very unlucky. And I'm sure that doctor, was practicing all these pillars of medical ethics, but it was just the wrong place, wrong time, wrong patient, mother. All right. So point is, read up on this document on Google. Just go and search for it, and you will be solid. Is the Bible is the holy grail of medicine, and if you know this, if you're familiar with this, you won't go wrong. So we will cover the main points that I want you to take away in the following slides. So the 4 main domains of the GMC. The first one is knowledge, skills, and performance. So this is just knowing your stuff, the stuff that you've learned in medical school, and continuing to learn on top of that. All right, and same goes for your skills. Then you've got your safety and quality. We've got communication, partnership, and teamwork, and then maintaining trust. And I think the maintaining trust part is probably the most important one here, because GMC, they take everything very seriously in this document, but when it comes to somebody not maintaining the public's trust in this profession, they take that very seriously, very, very seriously, and there will be consequences if you undermine that. Okay. So with regards to professional boundaries, so from domain 1, so if we look at domain 1, which is knowledge, skills, and performance, and from domain 4, which is maintaining trust, I've got 2 points from there. So wherever possible, avoid providing medical care to yourself or anyone with whom you have a close personal relationship. So it says wherever possible, but just try to extend that to forget the first 2 letters and avoid providing medical care, unless it's an emergency and that close person next to you, it requires urgent medical care, and you're the only practitioner there, and it's still going to be quite a while for the ambulance crew or someone else to come. Then it's valid, and you could probably defend that. But it's a well-known thing that you are not going to provide care to your brother, your sister, your family members. And if they are asking you a question, you do listen to them, you do provide your opinion, and you follow that up with, you should go and see your GP, okay, or you should go and see your own doctor regarding that. Okay, you do listen to them, because it's equally wrong to not listen, to a family member or a friend. Listen to them, let them know what you think, but equally follow that up with, I'm not your doctor, I don't know your background and history and what medications, etc., you're on. So what I would advise is you go and see your own doctor. Perfect, case closed. Next one, we said maintaining trust. So domain 4, point 53 from the good medical practice by the GMC. You must not use your professional position to pursue a sexual or improper emotional relationship with a patient or someone close to them. So this is very important. I'm not sure if you guys will have to do the SJT before you start a FY1 job or FY2 job here in the UK, but we all have to do situational judgment test, and it's based a lot on the good medical practice. And I remember there being a lot of these questions in practice. So if you have a patient, if you know their family member, etc., sexual relationships or emotional relationships are off limit, and it does not matter if it's been a year or 2 years or 3 years or 5 years. If that patient has been under your care, it's off limits. As simple as that. And you don't want to go down that route. Love is a special thing, I must say, but I'm sure there are plenty other people that you can find other than your patients. All right. Right. Let's move on from that. So domain 4, again, maintaining trust. You must be open and honest with patients if things go wrong. So I think the next big thing I just want to highlight is offer an apology, put matters right. So A, B, and C, put matters right, offer an apology, and explain fully and promptly what has happened and the likely short-term and long-term side effect or effects. So in my case, it was my DATEC story. So this was my first rotation in medicine of elderly. I had a medical student working with me, and I had asked the medical student to rewrite the Cardex, the medical drug Cardex, for one of my patients because it needed to be rewritten. And there was actually 2 Cardexes, not one. And the medical student rewrote one of them, but not the second one. And there was space left to rewrite the second Cardex's medications into this new first Cardex, and that didn't take place. So when nurses were giving the drugs, they thought the new Cardex was the only Cardex, and the second old Cardex was no longer in circulation, as to say. So the 2 medication, the apixaban, the blood thinner for the patient was on it for atrial fibrillation, blood thinning to prevent clots going up to the brain and causing a embolic stroke. So that was missed for approximately 3.5 days. And along with that, his metformin, which he took approximately 1,000 milligram of BD, was missed for about the same time, 3.5 days. So it wasn't that I left it out on purpose. I wasn't meaning to cause harm to the patient. It was just an unfortunate situation where I overlooked the fact that I was practicing with a medical student who doesn't have as much experience, and I should have actually looked at the whole folder, which and found that there was other medications that the patient was taking. Anyways, that happened. The nurse picked it up, thank God. She came and spoke to me, and I had to do a DATEX form, which basically asks you what happened, how do you think you could improve next time, etc., etc. And from this, nothing actually happened to me as an individual. I had to go and speak to my consultant supervisor and let her know what happened. I had to apologize to the patient. I had to tell them what happened. I phoned the family member because the patient at times was delirious. So I said the right thing to do is let's phone up the son as well and apologize and let them know what's gone wrong. And I told them, you know, the fact that you weren't on a metformin, your blood sugar levels have been high for the last few days, but we know why now. We'll get that back to normal. And as for the Pixaban, you know, we don't think it's caused you any short-term or long-term effect because it's still in your circulation for that time, and we'll get back on it. So no harm caused from that scenario. That was my DATEX story. Like I had to fill out a DATEX form, and you will become familiar with these when you do a job here in the UK. I'll leave that there. Okay, I think if you just understand this one, I think it'll take you far in your career, because this happens all the time. Things go wrong and you just need to apologize. Apology will take it to a point where the issue is probably not going to go any further. Okay, if you don't apologize and if you leave it, then patients get angry, all right, and then they take things further. So all you need to do is offer an apology and say you're sorry, and most of the time that will be it. All right. So again, we'll move on to the next point here, domain 4, point 62. You should end a professional relationship with a patient only when the breakdown of trust between you and the patient means you cannot provide good clinical care to the patient. So I don't think this one's of too much relevance to you, but I think the important thing to take away from here is that you have a duty to your patient to provide good care, and that should only be otherwise considered. You know, you cannot provide care when something like this happens. So I've seen this when I was in medical school, where the GPs, a patient came in who is known to be trouble, and he's been to prison many times before, and he comes in for an appointment and he's being very loud and aggressive in the consultation. So the GP says to the patient, well, I'm going to have to ask you to leave. And if this continues, this kind of behavior continues, I unfortunately won't be able to provide medical care to you because I'm putting my own safety at risk. So there are times when you're able to say, hey, I'm going to walk away from this situation and not provide care. All right, when your own safety is at risk. Right. Then we'll move on to confidentiality. So from domain 2, which if we go back here, is safety and quality, and then domain 4, which is maintaining trust. So safety and quality, you must treat information about patients as confidential. This includes after a patient has died. This is a very simple one, but it's a very important one. So let's say something happens at hospital. You are not allowed to come back home and tell your parents about the nitty-gritty details of who this happened to. It's okay to come back home and say, oh yeah, I had a patient, they had a heart attack, and then we had to do initiate CPR, and it was very traumatic for everybody because the patient died. Fine. What you don't want to go into is, oh, mom, yeah, it was, for example, here in Scotland, the Pakistani community is not that large. So if it would be absolutely wrong for me to come home and say, oh, yeah, this happened to so-and-so from the Pakistani community, that's confidentiality broken right there. All right. So be mindful of that, and be very mindful of confidentiality when you go to cafes and restaurants and you talk about your patients and what happened at hospital that day. That's when things go wrong. Somebody is in that restaurant and they know who you're talking about, even though you haven't mentioned the details. So just be very careful when you're out in public and talking about what's been happening at the hospital or GP practice, etc. All right, because there have been scenarios where people have been pulled aside for doing exactly that. Right, domain 4, so maintaining trust. When communicating publicly, including speaking to or writing in the media, you must maintain patient confidentiality. And this kind of just goes alongside with what I was just mentioning there. You should remember when using social media that communications intended for friends or family may become more widely available. So exactly what I just mentioned in regards to restaurants and out and about, cafes, etc. And that can be further expanded to social media. Okay, so very careful with what you say on social media. And not only about patients, but remember, you as a medical student, you are already part of the medical community. You represent the profession from the day one that you entered medical school. All right. So what you say, it should be seen as if a doctor, a professional, is writing on the internet, and be careful what you say there. Because again, there's been times where the GMC has pulled up people. There was a medical student who took Tom Hanks' famous quote, "I will find you, I know where you live, and I will kill you," etc., etc. This poor medical student took the photo of the meme of that and put it on the internet, intended at somebody, and the GMC found out about this, and he was taken to the tribunal, and it was decided that no, you're not going to continue medicine anymore. The poor guy never even graduated with a degree. Right. Capacity. Okay, so we're kind of moving away from the GMC guidelines, and we're going to quickly cover what capacity is. So the GMC said that we should assume capacity unless proven otherwise. Okay, so patient comes to you, you are going to give them full autonomy, one of the very first pillars of medical ethics, and you're going to say you have capacity, you have autonomy to make your own decisions, and you can further assess that in your conversation as you're speaking to this patient, and it's just kind of working in the background of your head as you're talking to them. Are they able to understand what we're talking about here? All right. Are they retaining the information that I'm telling them? So, for example, just on these first 2 points, sir, I'm speaking to this 19-year-old, right? Sir, I'm going to take, I'm concerned that you've got appendicitis, and I would like to offer the treatment for that, which is appendicectomy. And as I'm explaining all this, I'm trying to get consent for theatre. I wouldn't be doing this, by the way, because I'm not, I'm just an FY1. It would be a surgical registrar or a consultant who would do this normally. You only take consent for things that you are familiar with. Okay, that's important. So we'll cover this in a second as a doctor, right? So I'm thinking, is this patient understanding the fact that they need urgent operation here to take the appendix out, otherwise they may well die? Are they understanding that? And if they are they understanding the procedures, the risks, and the benefits of this treatment? Are they retaining this information? That's the second point. And then are they able to communicate that back to me? So for example, something that would concern me that they're not retaining this information is I come back in 2 hours time and they're like, so what's happening, doctor? And you tell them we're taking you to operation. He's like, why are you taking me to the operation? Ring, ring, ring. Patient's probably not got capacity anymore. Let's continue with this. So things which may impair a patient's capacity. Okay, so learning disabilities. So recently we came across somebody with Fragile X syndrome, and Fragile X syndrome is associated with autism, and it's also associated with a low IQ. That's the learning disability. Then delirium. Well, I did medicine of elderly. It was everywhere. You walk in the ward, it's like delirium, right? And a lot of patients had what we call in Scotland, only in Scotland, an adult with incapacity form. All right, that's AWI for short. So that is filled out when somebody does not have capacity. So loss of consciousness would be another example, or dementia. But they may still have capacity to make certain decisions. For example, even with the learning disability, the example that was given of the Fragile X syndrome, that patient still had capacity to refuse me taking bloods. All right. So when you fill out one of these forms, the AWI, right, what you're filling that out is for something specific, and you need to list that. So, for example, I would say the patient that we were dealing with did not have capacity to make decisions about going for an operation for, I don't know, taking out a tumor, taking out the gallbladder, taking out the appendix, or whatever, right? But he understood why we do bloods. Okay, he understood that much. So he has capacity for making decision, does he want bloods to be taken or not? Right? I hope that makes sense. So operation versus blood, that's two very different things, right? And then, I had another patient who had delirium, and a patient had suffered a stroke, and a PEG tube was being decided, should we continue with the PEG tube or not? Or should we stop feeding and allow the patient to die with dignity? Now, the son wanted a PEG tube to be inserted. We decided to refer her to the surgeons to get the PEG tube put in. That didn't go well. Couldn't have the PEG tube. Then other thing was stopping NG feeding versus continue NG feeding. The patient was delirious. She did not know where she was. She did not know where she wants to go, but she was adamant that she does not want the NG tube. How do we know that? Well, we asked her multiple times. Other things, the stories changed, but one thing that did not change was, what was consistent was the NG feeding. She said, I don't want it. 3 different times, 3 different days. But when the son came, right, this is now very important, right? When the son came to speak to the mom, she changed her mind. She said, I do want to continue NG feeding. Now, one might say, well, there might be coercion there. The son has forced the mother to continue NG feeding. But hey, we're medical professionals. That kind of, are we forcing treatment or investigation onto patients? That's more to do with us, right? We're not allowed to force patients to do things. The patient has to make that decision voluntarily about investigations or treatment. But when it comes to family members, they can help, or friends or carers, they can help the patient make a decision. So when the son came, he helped the mom make the decision that she should continue feeding, and that's what happened. We'll cover this in the next slide a bit more. So this is where the concept of maximizing capacity comes in, and I literally took this from the GMC website. So I would look this up in your own time as well. So the ways that you can maximize capacity is time and place that suits them. So for example, delirium, it tends to be worse at night, or if somebody has dementia, their symptoms may well be worse at night. And it might be a wise thing for you as a physician to do is have that chat with the patient when they are less likely to be delirious, which might be in the morning. All right. Other way that you can maximize capacity would be having friends, family, next of kin, carer there who can help recall information or facilitate in that decision-making process. As I mentioned with the son and the mother who was delirious in regards to the NG tube feeding. Alternative communication methods, so written translators via family, friends, carers. And the example of Fragile X syndrome, we knew that the patient has a learning disability, and we would only go into the room when there was a family member in the room or when the carer was there, to allow us, because they know the patient more than we know them. All right, so it's best for them to be there when we're trying to communicate. DNA CPR, this is a thing that we did day in, day out on MOE, medicine of elderly and stroke, in my first job. So do not attempt CPR. So the main thing to do here is, this takes practice. The one thing that you need to know is that this is a medical decision, right? The second thing that you need to know is there are, as it says here, must either, one or two, right? If the patient does have capacity, right, so they're not delirious, they haven't lost consciousness, and they're in a state of mind to make decisions, which means, if we go back to the slide here, they're able to understand the risks and benefits of doing a CPR or not doing a CPR. They're able to retain that information, and they're able to communicate their wishes to you, the physician taking care of them. They have capacity, and they can make the decision about DNA CPR. Okay. Then there's the discuss with patient's next of kin, family members, if the patient does not have capacity. Okay. For example, if they have an AWI in place. And that's very important. So the scenario that I want to quickly share here is I had to fill a DNA CPR out for a patient who had a Parkinson plus syndrome, and they were not able to communicate verbally. But she had capacity. She was able to understand the benefits and risks. She was able to retain the information, and she was able to communicate it back to me. 3 things were present. I went and I spoke to her, writing on the board. She communicated back to me that she does not want DNA CPR. And that decision was informed because I explained to her what the benefits and risks are of going for it or not going for it. And I said to her, with your disability, you're not able to communicate, and other disabilities, I would say that it would be inappropriate for us to put you through that traumatic event and to leave you with more disabilities than you have already. And she said, I agree. She said, I already can't talk. I do not want to be resuscitated. So I filled out the form. I left it. That evening, the daughter comes, who does not have power of attorney, and is angry that we did not have her present when she made that decision. See, this links back to maximizing capacity. Now, I did not maximize capacity. Did I need to? No, because the patient had capacity. She was not delirious. She was never delirious throughout her stay in hospital. So it was the right thing to do. But equally, it is always better to communicate or ask the patient to communicate this with their family members, or at least ask them, do you want your doctor to be present before you make this decision? So I'm just mentioning this because it's always good to involve family members when you're discussing stuff like DNA CPR. And then the second example is the story in AU2. So admissions unit, when a patient came in, we filled out AWI, patient with incapacity, is not able to make any decisions, or not be able to make certain decisions about certain procedures and investigations. We filled that out. We also filled out a DNA CPR to not attempt resuscitation. And then we had not discussed it with the family member. And the patient was leaving the hospital to go back home, and we had not discussed it with the patient either, because they had an AWI form in place. So we're in this tricky situation. We're really busy in the ward, and somebody needs to do one or the two, right? The patient now has capacity, right? Because the infection is over. They're no longer delirious. They have capacity. Somebody needs to either speak to the patient, or somebody should have spoken to the family when they did not have capacity. So we were in a tricky situation. The ambulance is here to drop the patient back home. What do we do? Well, we said for the ride home in the ambulance, the patient is for DNA CPR. And that was the decision that we took. And from there onwards, the patient is still for resuscitation until someone puts out a community DNA CPR form. So what I did was I phoned up the GP and I told them, this is what's happened. Can you please discuss DNA CPR in the community with the patient? So just to kind of cover that DNA CPR, and I hope that's of benefit to you, that scenario, because I thought it was for me. Consent. So as we mentioned earlier, consent, one of the points, if you look at the secondary point to begin with, voluntary. So it must not be forced on somebody. So I was doing my anesthetic job, and we would have liked the patient to have a spinal, but the patient said, no, I want GA. I want my general anesthetic. And the anesthetist asked a few times, no, or said, I think it would be better for a spinal, blah, blah, blah. And in the end, just about as we were about to give the GA, the doctor asked, look, I'm not trying to pull your arm here. I'm not trying to force anything. I just want to know why you don't want to have the spinal. And the patient told us that, next door neighbor had a spinal and then got a clot and died. So there was a reason why the patient didn't want it, and you just stop, right? You don't force things on people. Explore their concerns, absolutely, but don't force things. So specific decisions and time, right? So, if you take consent from a patient about bloods, hey, I'm going to put bloods in place, or I'm going to put an IV cannula in and give you some fluids, that's consent for that specific thing. They haven't given you consent for a CT scan, right? Or if they've given you a consent for investigation, they haven't given you consent for operation. If they've given you a consent to feel their axilla for lumps, and you do find a lump and you want to do a breast exam, they have not given you consent for breast exam until you gain consent for the breast exam. So that's very important. Consent is specific and is timely. So if somebody gives you consent to do take their appendix out on the 5th of April 2021, that does not mean that consent is valid when you change that appointment date for next month or something, or next day even. So it's timely. And then patient must have capacity for consent to be valid. And if that is not the case, then you as the physician, if the patient is not able to give you consent because they lack capacity, then you as the physician have to make the decision in the best interest of that patient. And if they have a power of attorney because they lack capacity, then they have to make the decision. And of course, the consent, before somebody can give you consent, you have to inform them of what that exam or investigation or treatment involves. And if it's not informed consent, right? For example, you haven't told them that there's a risk of us knocking out teeth when we are doing some sort of ENT procedure, or when we are about to do a general anesthetic and we're going to be putting a endotracheal tube down your throat, that the scope can actually damage your teeth, then that's not an informed consent. And if you do happen to cause harm to the patient, i.e. knock their teeth out, then you may be up for investigation. The patient may decide to sue you because you didn't tell them that you will knock their teeth out. I mean, we have been told stories that patients have taken doctors to court because, silly as it sounds, for a surgery, the patient was not informed that there will be a scar. How silly is that, right? So you have to really inform your patients as to what is going to happen and what are going to be the consequences, i.e. a scar or a broken tooth. So that's the good medical practice. I would, again, highly recommend that you read up on this. Medical practitioners tribunal service, I wouldn't worry too much about this. I mean, it will only go to that extent, right? That's the highest level that you will be taken or to the courts if something goes wrong. All I would say is if something goes wrong in hospital, as I said, apologize to the patient, or if it's a colleague, apologize to your colleague, and that will be the end of it. Put out your Datex form. Don't try and lie. Don't try and manipulate the information. Be as accurate as you can. And this will probably get dealt with internally at the university or within your department or within your hospital. And it won't ever even go to the GMC. But let's say things do go to the GMC, and I said, they might tell you advice. They might tell you to stop working for a couple of months. They might tell you retrain, blah, blah, blah. And it's very rarely that things go to the tribunal service. So I wouldn't worry too much about this. If you want to find out a bit more, you can absolutely read up on it. I would say it's going to be a waste of time of yours. What I would recommend you put more time into is reading up on the good medical practice, and then you won't need to worry about other things. All right. And one other thing I would like to mention is for the good medical practice, there are other documents. For example, protecting vulnerable patients and children. There's a good document about that. I would read up on it. So good medical practice is where you begin, but there's a lot more from the GMC. But start with this. All right, so defense unions, this is very crucial. So there's defense unions, and then there is the BMA as well, British Medical Association. So I would recommend that you sign up with the British Medical Association, and then you also sign up with one of these two, and I think there's probably more, but these are the two that came pretty much every year to our medical school, and we would sign up to one of them or both of them. So in FY1, you can sign up to both of them, or I think you can sign up to 2 unions. And then from there on, you have to choose one. So I've had contact with one of them. I can't remember which one, but they're both well known in the UK. You can sign up to them when you're in medical school as well. But I'm not sure if you can as international students. I would check. All right. But they have provided very good advice whenever I've been in trouble in medical school or just before starting my job. Whenever I've been in trouble, I go to these guys. They give you free advice as students, right? As medical students of the UK, they give you free advice, and then it's not a costly membership from there onwards either. So I would highly recommend it. So we'll quickly go over scenarios. Husband comes into your GP practice. He wants some information about his wife's cancer results before you speak to her, because let's say he doesn't want her to get upset if it's a poor prognosis, if it's a poor prognosis, she's going to die or something like that. He's worried that he doesn't want to cause her mental trauma, and he wants to know first. Here, can somebody from the audience tell me what you would do?
Okay, this is a bit of a difficult one because we don't have a chat function.
All right. Okay.
So I'm thinking
I will continue.
Yeah.
Okay. I will continue. Right. Sorry. So in this case, you are absolutely not allowed to tell the husband what the results are without getting permission from the wife. And the best way to do this, so a cancer diagnosis is tough, and not only for the patient to hear, but for you as a physician as well. And it's always good to have a family member there, or if the patient wants a family member to be there. So it is always suggested, if a patient comes in on their own, let's say the wife had come in, I would have said, would you like to have, your husband or someone else come in with you before they actually came in? It would be better if you had that chat. And if they both come in together, it'd be best to give her the diagnosis or break the bad news like that. But for you to just give the husband results of the wife, that's not right. That's absolutely wrong. So I'm originally from Pakistan, and I was there recently. I could literally just pick up my phone and phone up the laboratory and ask them, what is the result of my mom or my dad or this or that? Not that I did it, but that's the environment in another country. Here in the UK, this is breaking confidentiality. Okay, so it seems very basic, but if somebody is coming from Pakistan, from an environment where you just give that information out to the husband. I mean, my mom was telling me that when my dad had a stroke, the doctor actually just spoke to my mom and gave her all the details. But in the UK, you wouldn't do that without getting consent from the husband in that case first. All right. Or if they lacked capacity, that's a different story then. Right. Scenario 2. Man or a woman comes into your GP surgery. They require a breast or genital examination. Patient is refusing a chaperone. So there's 2 points to this. Point number 1, when somebody comes in, remember that child lymph node and then query sexual assault scenario that I presented right in the beginning. In such cases, you normally don't have a chaperone. It's a child. And I would really hope that the public trusts us to examine children and hope that, believe that we're not going to do anything like that, especially when a parent is standing there, or even if they're not. And I hope they know that. So obviously something's gone wrong in that scenario. When it comes to scenarios like these, especially adults, or even if it's a teenager or a child, I don't know what age it would be. Whenever, just whenever you're doing intimate examination, groin, breast, genitals, digital rectal examination, anything like that, get a chaperone in the room. It is absolutely necessary. The chaperone does not need to be of the same sex as the patient. If the patient is a female, the chaperone, the nurse, could be a male. That's okay, as long as someone is in that room. And having a family member does not count as a chaperone. That's very important. It has to be somebody from your own hospital team, medical staff. Second thing about this is that patient is refusing chaperone. In this scenario, you would simply tell the patient that, first of all, explore their concerns. Why are they saying they don't want a chaperone? There might be a valid reason. Second, tell them that you as a professional are putting yourself at risk by not having a chaperone, and therefore you're going to, you will not be able to carry out that examination. And in turn, you are putting the patient's health at risk. So explain it like that. And they might be like, oh, okay, doctor, fine, I'll have the chaperone. So explore, explain, and they might change their mind. You haven't forced anything onto them. And it's for your own benefit and the patient's benefit to have a chaperone in the room. Right. Scenario 3. 14-year-old female comes to your GP surgery requesting the pill. Right. So this one is to do with the Gillick's and Fraser's competence, Scotland and England. And the main thing here is that if a child is coming asking for the pill, explore why. Probably because they are participating in sexual activity. The second thing that you need to explore is, does this patient have capacity? Remember the 3 things. And if they do, they can have the pill, but there's other things that you need to explore. You need to tell the patient, the teenager, that it'd be advised that we get your parents involved. If the patient refuses and they have capacity, then we don't have to get the patient's parents involved. The other thing that you must explore is sexual health, okay? And the other thing that you must explore is the age of the person they are practicing sexual activity with. And if the age gap is too large, let's say they're not even at school, that's very concerning. And then if that is the case, then you need to get the parents involved. Okay. And whenever you're in trouble, let's say you're not sure what to do, right? You tell the patient, hold on, right? Hold on, I need to find out more. And you can contact your medical defense unit. Okay. If that's going to take too long, you can ask your colleague what to do as well. Okay. So don't ever feel like you're alone. That's very important. Don't ever feel like you're alone. You can ask for help. Scenario 4, a medical student is found to be reading notes on the computer. Yes, so this has happened to one of my friends. He was reading up on notes about his own medical records on the NHS computers. This is off limit. This is absolutely wrong. And the reason why this is wrong is because in the UK, if you want to access your own medical records, you must request them. You cannot simply, as a professional nurse, doctor, you cannot simply go into the notes and look up your own results. And equally, you cannot look up somebody who you know their results. You can only look up the results of the patient that you are looking after. So there have been scenarios of people looking up notes of Alex Salmond. He's the former first minister of the UK, or of footballers. Absolutely wrong thing to do. And you will be punished greatly for doing something like that. So my friend, he was pulled up by the medical school. Nothing happened. Well, he was told not to do that ever again. But just remember, you're not allowed to look up your own notes or somebody who you know's results. The only people that you can look up the results of are the ones that you are looking after or you're doing a medical research on. Patient reading their own notes when admitted as patients. So on the ward, you will often see patients pick up their own notes and start reading them. That's again off limits. If you see a patient doing that, you tell them that you're not allowed to do this. You take the notes off them and you tell them, if you want access to your notes, you need to request them through the requesting process, whatever that is, from the NHS. You cannot read your own notes. Simple, no matter who you are. Okay, scenario 5. So patient visits GP surgery and says she is going to kill herself. Kill her husband. You are concerned as she appears to be serious. You are unable to stop her. When, let's say, you tried to stop her, you were unable to. Patient known to suffer from psychosis. Right. So this is to do with the Mental Health Act, and also to do with the your duty as a doctor to protect others, the public health, basically. So this is a really tough scenario to be in, absolutely. But ultimately, what you need to do is you need to protect that husband. If you are legitimately concerned that this patient is going to go and do what she say she's going to do, you need to literally pick up the phone to two people, and you are breaking confidentiality here, okay, to a certain extent. One, you need to pick up the phone to the police, and two, you need to pick up the phone to the husband. And if you want, you could always speak to your medical defense union as well. The other people to speak to would be, of course, the community psychiatrist. Yeah. So here, you know, you need to protect somebody. If you need to protect somebody and it means you have to break confidentiality, you do that, because protecting someone's life is more important than breaking confidentiality. If you can do it in a way that you're not breaking confidentiality, all the best. Well, all the better. So scenario 6, last one, a consultant asks you to clerk in a patient AU2 admission unit. What are the 3 few things you must do when you meet the patient? So this is, again, you know, having been in Pakistan and seen the medical schooling system and how we train people there. I'm not saying this is how the people are trained watching this, but there's a huge difference between how we're taught here in the UK and Pakistan, because that's the only country I've actually seen the training in. So based on that, I might be making this too simple, but it's always good to reiterate this, because we have to do this in every single OSCE station in medical school and every time we see a patient here in the UK. And if you don't, then you might get pulled up. So 3 things are, who are you, right? Hi, my name is Dr. Mohsin Mohammed. I am a junior doctor and I'm looking after you, okay? Second thing would be, who are you for me to ask the patient? Can you confirm your name and your date of birth, just to make sure you're actually looking after the right patient now? For example, you're just about to take bloods. It'd be good to know whose blood you're taking so you don't mix up patients. And the third thing is actually explain to them what you're about to do. Okay, and then third and fourth would be ask them if they have any questions before you do that thing. So for example, you know, I'm going to examine your abdomen, where are you sore, etc., and explain to them that they might be sore. And if they say, I don't want you to do that, oh, sorry, I guess the other question is, are you okay for me to proceed? And if they say yes, I've never had a patient say no to me, by the way. So it's kind to just do that. And a lot of the time patient will look at you like, is this guy stupid or something, asking as a doctor if it's okay for them to take bloods or examine me, etc. But trust me, you're better off asking them than not. Yeah. It's absolutely wrong to just go into the room and pick up the arm and be like, okay, I'm about to take bloods, and put a needle in there, tourniquet needle, right? That's absolutely wrong. Name, your grade, Mohsin Mohammed, FY1, junior doctor. I would like to take bloods. Can I confirm your name and date of birth? Are you okay with me taking bloods? Do you have any questions? Do all of this before you proceed. And that's, you know, again, it's an informed consent that you're doing. That's basically what I've highlighted here. And that's the references, and that's 59 minutes, and that's us. Okay, so I think this would be a good point to take questions.
Okay, so thank you so much, Dr. Mohammed. Okay, great. You guys can see my screen. Just quickly before we move on, Anil asked me to give him a shout out. Anil is a doctor who is running the SME postgraduate program. So he helps out with a lot of, you know, dealing with your CV and sort of, you know, preparing for your exams, so on and so forth. So definitely check him out. And I also wanted to ask everyone to, feedback's amazing. Feedback's really good. We really love feedback. So basically, please do fill in the form. As soon as you fill in the form, basically what will happen is we will get a certificate out to you for attendance. And at the same time, we will also send you a copy of the book Dr. Mohammed was talking about, so the Good Medical Practice. So we'll send you out a copy of that as well. That'll just get emailed directly to you. So you will get that as well. And then, of course, a big thank you to Lectorio. I'm just going to reply. So basically, you should be able to see the link for the feedback form in the Q&A. Yeah, it should be there. Wonderful. And a big thank you to Lectorio, for being our sponsors today. Again, all-in-one study resource for medical students. The amount of times I've said that. But no, they're honestly great. So yeah, definitely check them out. And I think what we're going to do is we're going to send everyone out a 50% discount code. I'm just going to let you know another code's actually Study Medicine Europe. So I think when you're checking out of whatever plan you end up buying, it's 50% off, which is pretty good because Lectorio is a lot of things, but costly, you could say, is one of them. So it's really nice to get something great for cheap. Okay, moving on to questions. So basically, Dr. Mohammed, what I'm going to do is I've had people messaging me questions, emailing me questions, and then people asking questions here.
Yep.
So I'm just going to read them out to you, and you can just take them as they come. So I think one of the first question is asked by anonymous person. Who should you prioritize of the family of the patient? Let's say he has a wife and his parents are both equally involved, but not collectively involved.
Yeah, so I think this is a tough one. I think there was another question which I've answered, but in regards to this specific question, I think this is a tough one, and ultimately, who you should prioritize. Okay, so the point is you don't need to prioritize anybody, to be honest. Unless they have a power of attorney, all you're doing is just listening to them. It's now your duty as the acting physician of the patient to make the right decision, to do what is in the best interest of that patient. Okay, and it's a medical decision that you're making. All right. So if for example they have issues between them and this patient wants surgery, this patient doesn't want surgery, well, listen, it's a medical decision. We're going to do the surgery or we're not going to do the surgery. You guys can argue all you want. But what really comes down to is, does the patient family have power of attorney or not? And it's that person that we really listen to. And if there's argument, you can always sit down with them, always listen to family members. And probably if you have a good chat with them and explain to them what you want to do, they will all just come on board.
Thank you so much. The next question is from Warda, who asks, does the discipline or the burden of the overly safe GMC cause the system to be less productive or counterproductive? So I think too much red tape really is what she's asking.
I think we could probably have that argument for days. Ultimately, I would say both, because less productive, because we have to document every little thing that we do, and protective medicine, as the term is called, you do things just to cover your back, and so for there, it's less productive, counterproductive, but equally it can be overly safe, could be better sometimes for the patient. And if it means, if this burden and discipline means that we're doing better for the patient, then so be it.
Absolutely. I think we see this a lot, especially in third world countries. It's obviously you have a lot more infection, you have a lot more of the bad things, but at the same time, the process is so streamlined and effective and efficient. You can have a patient in and a patient out on the same day.
Yeah.
Whereas with the NHS, it's just paperwork you have to deal with. Another question by Noor was to clarify, what is the situation for a patient suffering from delirium and doesn't have family members available immediately to consent an emergency treatment needed urgently?
Well, yeah, in that case, so this goes back to doing the right thing, acting in the best interest for the patient. If you and the medical team believe that this is the right procedure, then you go ahead with it. If there's nobody there to help you make that decision. Ultimately, if the patient does not have capacity, it's down to you to make the decisions, unless there's a power of attorney.
Absolutely. Martina asks, what do you do to declare? What do you have to declare to the GMC, and to what extent do you have to declare it?
So this is a really, and this is exactly where I messed up before starting my job. So what had happened early in my career was ultimately I had lied to somebody, and the issue was that the medical school were aware of this, and they decided not to do anything. And they said, "Oh, young chap, something's gone wrong. We're not going to do anything about it," right? But he's learned his lesson. So that happened in second year. But when it came to finishing medical school and declaring things to the GMC, I did not declare that, and the medical school had already passed that information on to the GMC, or something like that. And ultimately, I asked the GMC, "Oh, do I need to declare that?" After the declaration process was over, and they said, "Yes, you should have." And then they asked me to do a reflection on what had happened in second year. And then they asked me to do a reflection on why I had not disclosed it this time. And I swear to God, I did not sleep for 2-3 weeks while this whole process was going on, because I thought I wasn't going to get in, become a doctor. So if you're
Honestly, I feel like, with doctors, it's the GMC's like, it's just like having parents in the profession.
Yeah.
They make you reflect. They can ground you for sure. So really, honestly, I just feel like it's we need that there as well, don't you think?
Yeah. So going back to your question, you absolutely need it. And to the person's question here, the issue was, see, when it came to declaring, I did not read the information as to what to be declared. So they've got a document, the page that you go and declare, but there's another document that you need to fully read as to what you need to declare and what you don't. Well, they don't tell you what you don't need to declare, they just tell you what you need to declare. I did not read that other document, you see. So all I read was the headlines, but not the details. And when I read the headlines, and I thought, oh, I don't need to declare it. What I should have done was I should have just picked up the phone and just asked them right there and then. If you're uncertain, I cannot tell you, right? When it comes to that point, you will have that document and you will have GMC's email and number. And if you want to clarify, you can always clarify.
Yeah, absolutely. I think with us over here studying abroad in IMGs, yeah, even the process is a little bit more strict, because I think what they've recently, this has always been there, but they've recently started becoming more strict on it, is you need to get a police check in the country we're living in.
Right.
And I think a lot of people went back and they didn't do that. So people were flying back to Bulgaria, wherever it was, just to go to the police station, because over here nothing gets done online, everything's in person. So just to go to the police station and get a simple form saying, yeah, you're cool, and then they had to fly back. And I'm just sitting there, I'm just like, and you couldn't get somebody else to get that for you as well. So they've not went online, but they made that happen. Muhammad asks, what if a patient doesn't have capacity but tells you they don't want an operation before going unconscious? But then the family, at the same time, the family is demanding you do the operation.
Boy, I would not want to be in that situation. I would let my consultants deal with that. I trust me. Like here's the thing. These at your stage, these are scenarios which are almost film-like. They are, in addition to that, you don't need to worry about them. Okay, because for years, probably 5 to 10 years, you will never be put in a situation like that if you're working in the UK. So it's decision, like, I don't know the answer. Okay.
Yeah, no. I think mainly the other thing I was discussing with Muhammad the other day was, what if a patient physically refuses to, even let's say they're not in capacity and you have their family's permission, what if a patient physically refuses to allow you to do a procedure of some sort? For example, give her an injection or give her medication.
Yeah.
Physically doesn't allow that to happen. Are you allowed to
I'll give you an
restrain?
example. I've been in that many situation, many times. So in alcohol withdrawal, right? I've been in a situation where a patient ultimately died because not because we weren't giving him the treatment, but he was just so ill from it. But it took 6 people, 5 nurses, well, nurses plus other staff members on the ward, and plus me to get that blood off the guy. And there was a risk of needle stick injury for us guys. Okay. But we had to do it. The guy was so out of it, we had to do it. This was in my first rotation. Just not last night, the night before, I was covering surgical, and we had another patient with alcohol withdrawal, and the nurse told me, "Oh, we're not giving him IVs because he was very chaotic, and we've decided not to give them." I'm like, we need to give him those because it's potassium. Potassium is sitting at 2.5. This patient is going to have a cardiac arrest soon unless I get those potassium into him. She's like, "Oh, well, if you want." And the patient's not had any potassium in the last day, and his potassium from 3 days was 2.5. It's not increasing, and I'm so concerned. I just walk in there, and the patient is no longer delirious. I just tell him, "Hey, I want to give you some IVs." He's like, "Okay." I put the IV in there, start the potassium, ask my colleague to review him in 3 hours, give him more, and that's it, sorted. If you're really concerned, you will have to pin them down. And the AWI sort of allows you to do that for medical procedures. So in the UK, in Scotland it's called AWI, and in the rest of the UK it's called something else. And then there's the Mental Health Act or Detention Act, which is to allow doctors to carry out psychiatric treatments, whatever they may be. For example, some drug for psychosis. Whereas, for example, an NG tube insertion for somebody who has eating disorder. See, that's a tough one. That might be under the Psychiatric Act, or it might be under the AWI, because it's a physical problem we're trying to treat with the NG tube, which is falling in the AWI, but it's led because of a psychiatric one. So psychiatric issues, physical issues, and then you've got AWI, Mental Health Act, and you can use whichever is most appropriate to give the treatment if it needs to be given there right then and there because the patient doesn't have capacity anymore.
I think actually something somebody wanted to ask was basically, so with my instructors, I always put them in an ethical scenario. That's a really funny one. And this was something I actually read online. And like you said, it's a very film-like scenario to be in. But it was the sort of idea where they saw somebody on the street collapse, and they were asking them, so they went up to them, and they were obviously doing their primary survey, they were doing the doctor's ABC, but when they tried to get exposure, the person had a "do not resuscitate" tattoo on their chest. Now this is a difficult scenario for them, because essentially I was asking this in a lot of interviews to a lot of my instructors when I was interviewing them. And the idea wasn't, I wasn't really looking for a right answer. I was just looking for how they reasoned around it. But I mean, I think it's a bit of an ethical dilemma in that sense, because in the actual scenario, in the actual way it was described, it was "do not resuscitate," and it was a little scribble at the side as well, which was seemingly the person's signature. And he didn't have an ID with him, so we couldn't even confirm his identification or try and find out if he actually had a DNA CPR. So what would you do in that situation, considering you've only got minutes to really give this person CPR and try and save their life?
That is tough. That is tough, because ultimately we would normally decide that on a legal form is in place, signed by doctors, 2 doctors, and it's got the patient's name on it, etc., etc. So I mean, and it's dated. That's important. right? The medical form is dated. And if a person is carrying that, and they're like, who carries things now? You don't carry your passport. Some people don't even carry their license. But if a person is carrying that legal document, well, this person does not want to be resuscitated, right? But when it's tattooed, it's you're like, I'm not sure. So I want to be on the safer side, and to try and save this person's life, and then in the hope that I'm on the right line here, and I hope that this patient doesn't want me to resuscitate. But they've got it all tattooed on them, right? But it's not legally binding, is it?
Well, I mean, this is the thing, right? Basically, when I actually read into it properly, so the A&E doctors resuscitated him successfully.
Right.
And basically, obviously, at that moment, they couldn't find out who he was. So they resuscitated him successfully. They found out who he was. They found his DNA CPR. So they knew they shouldn't have resuscitated him. So they were like, okay. They start calling lawyers, they start calling the ethical board. It turned into a whole thing. And then the ethical board and the lawyers, and they were all like, the right thing to do was respect that on his body, respect the tattoo on his body.
Wow.
Like, disregarding the fact that he had a DNA CPR or not, that's enough to respect, because it's like, there is no chance that's there by coincidence or mistake.
Sure.
Like, what were the odds that he was drunk?
My friends took me out, got me drunk, and got that tattooed.
And like, what are the chances of that happening to someone, right? So especially the night before or something like that. And on top of that, it was just sort of because what's a binding contract? What's a binding contract more than a legally binding contract? It's on his person. It's from him. There's a signature over there. It's a statement, and he's expressing his thoughts. And really, that's the idea of a contract. It's you expressing your thoughts in a more official sense when you can't be there to do it verbally. So they were like, the right thing to do was respect. You guys shouldn't have done CPR. The reason this didn't turn into a nationwide issue was because 6 hours later, he went back into cardiac arrest. And at this point, they were like, okay, we don't need to do CPR. Yeah. So this is why it was only like a small article in the New York Times.
Interesting.
But I think this also goes back to the question of like, the one you already really answered actually was, what do you do if a patient does not have capacity and is alone is just the AWI, isn't it?
Yeah, AWI, and you just act in the best interest. And I think that is a very in situations like that where you're like panicking, and if I was on my own, I would 100% be starting that CPR, unless there's someone else who back off and think for a second as you're explaining there, and be like, okay, because your instinct is as a physician to save life ultimately. So yeah, it's a good scenario that you've
honestly, like, some of the people I talked to and like the answers I've gotten from this question, like, you'd be so surprised, because my favorite thing is when people try and reason around it. They've seen it, but they'll try and reason around it. They're like, oh, too much adrenaline, I didn't get a chance to read it. And one guy's like, I know read English. I'm just like, okay, like, I get you. And then, like, even for me, if I was in that situation, I'd be so tempted to just cover his chest back up and continue doing CPR, and like, oh, I didn't see it. But like, because obviously you want to save the person's life, that's your instinct. And if it turns out that it was him going out.
The interesting thing is, of course, this was done in A&E, right? If this was down in the street, I wouldn't even bother uncovering anything. I would just get started, because I wouldn't uncover until I had my pads there. Yeah.
But I was telling them in terms of them doing their primary survey to the book, properly getting exposure. Yeah. So just like, if you were ever in that scenario, and really, like, I think people always tend two ways: either they're too moral or they're too sort of legal in that sense. Where it's the morality, they'd be like, no, it's my job to save that person. Yeah. I have to save that person.
And this goes back to that question: are we being over treating and over protective and covering ourselves? And well, from my answer, you could say, Mohsin, you are the legally binding person, whereas, or trying at least, even if I'm failing, trying to do it by the books rather than doing the morally right thing. Yeah, no, and you know, the thing is, there's a spectrum to everything. There's doctors who will be at that end of winging it, and there will be doctors at the end of who do it exactly by the books. So, and we will always be somewhere in between that, and that's a thing that I've seen again and again.
Actually, turning that around, more so towards putting the orders onto the doctors. Could you refuse as a doctor to treat a patient, and under what circumstances can you do that?
Not treating a patient. Again, one of the ones we mentioned, if your own health is at risk. Other ones would be, for example, if it doesn't meet up with your belief systems. So, for example, let's say you are a doctor who is a Jehovah's Witness, and you practice the fact that humans should not be given blood. The GMC says that your beliefs and not your beliefs, your religions, some other things should not affect your medical practice. But if they are, then you can step aside, and you have to get another doctor to treat them.
Yeah. I mean, if you're a Jehovah's Witness and a doctor, like, I mean, they should really keep you away from trauma. Like, I just can't imagine you being an asset over there. Like, you just object to every second person that walks in. I remember, like, one of the teachers just cracking jokes about this. Like, my first day in traumatology was just like, is anyone Jehovah's Witness here? And I'm like, everyone's like, no. He's like, okay, good. I'm sure he's had someone come by and bring that up.
And in arguments, and he doesn't.
Actually, this one was actually a really big thing quite recently, because I remember reading about ACPs, and the reason ACPs are around is because, well, I mean, I think you could answer this better, to be honest. Does DNA CPR apply to all life-saving acute interventions, or only CPR?
So, for example, we recently had a patient who was going up to the theaters, right? And what they had said was, oh, we can't find the patient's DNA CPR form. And I'm like, he definitely has a DNA CPR form, because it's on the GP records from the community. And the family has told me as well, the patient's got DNA CPR. But, so the patient is going up to theaters, and I asked my senior, doesn't the patient need a DNA CPR form? He's like, no, because that's a different procedure. If the patient is to have a cardiac arrest on the table there, that's a decision for them to make. This is not binding with his DNA CPR form that he has from community.
Come again?
That's exactly what I said. And that's exactly what I said. I don't understand, because the patient has a DNA CPR. I would presume that's for every single thing. But ultimately, they were saying, no, that's decision-based. It's for me going around every single day and having a cardiac arrest, not being resuscitated. That's for that. For me to have a cardiac arrest on the table, that's apparently different.
Yeah. But then again, like, even CPR itself, like, it's one of many acute interventions doctors do to save your life. You know, if that's intubation, if that's tracheostomies, if that's if you're having a pneumothorax and they have to puncture that, like, it's one of many acute interventions. And I'm just like, because I think at a certain period, and you see this a lot, like when you start looking at respect forms and things like that, and who that's aimed towards. Some people are just ready to go, and they're ready to go in a peaceful way because they're living in a lot of pain. For example, cancer patients or people with chronic illnesses. And I'm just sitting there, and I'm just like, well, I mean, DNA CPR only does so much for them, And this is the thing, because I don't think anyone I speak to really, a lot of medical students I speak to don't really know what respect forms are, or what hospital advanced care plans or anticipatory care plans are. And I'm just sitting there, and I'm just like, actually, this is one thing I wanted to really ask you, to be honest. Like, do you, as a junior doctor, deal a lot with anticipatory care plans or advanced care plans?
Anticipatory care plans, yes. in the sense that, we would decide, we did a lot of this in stroke and MOE and here as well in ICU. We would, as an ICU FY1, I would go with the registrar and go see a patient and decide, is this patient for escalation or not? And you will hear this word a lot, escalation or not, or ward level care, or high dependency care is the ceiling, or is it all the way to ICU? So that's anticipatory care planning, and you can put that in place. And again, this is timely. It's for a certain thing. We've had patients come in during COVID in March last year. They have an anticipatory care plan in place that they're not for resuscitation, but then they came in with a stroke, right? They got thrombolized. They're much better, and they're having a little bit of a bleed now. And I phone up the consultant. I'm like, okay, is this patient for escalation or not? And his answer was, if there's a lot of hemorrhage, the patient's not. And I'm like, well, that means they're not, because that's what I'm asking here. If they continue bleeding. But, the patient was fine, and they just went home. And it was a 93-year-old. But a lot of the patients who come into medicine of elderly who are very ill and very frail and have a lot of disability, we would decide, ward level is the ceiling of care here.
Yeah, absolutely.
And we're not going to escalate. And well, you can always ask, you can always make the referral to ICU and get them to come down and assess. But that gets really annoying for them, right? Because it's a thing you as the physician should be making a decision on. But if you're really struggling, you can always ask.
Yeah.
Things like heart failure, they already have renal failure. How many organs have gone wrong? How many systems have already gone wrong? And I remember there was a patient who had COVID and then had a stroke, then developed renal failure in ICU. And I remember the consultant saying, if the patient had a stroke, right, and COVID, those two alone, or maybe renal issues, I wouldn't have admitted them. But at the time, all they had was COVID. See?
Yeah, that's tough. That's tough. Just listen to that. That's tough. So it's like, because obviously, I think when you start looking at the aspects of realistic medicine, it's very cutthroat in that sense, where you have to look at people and you have to be like, because I think it's a very painful concept for medical students to pick up until they've actually established themselves as doctors, that not everyone is savable, and then on top of that, you're the one to decide who is and who isn't. So it's obviously such a difficult concept, but like I honestly urge everyone and encourage everyone to go out there and start learning about HACPs and respect forms and trying to understand the patient's needs while sitting down. Like you said, I loved hearing this, where you go with your consultant and you sat down with them and you saw these conversations, because that's not so common in England from the junior doctors I've been speaking to over there. And a lot of them don't deal with it at all in that sense. And I don't even think I can ask a lot of people what color a respect form is, and they won't be able to tell me the color.
I don't know.
Yeah, that's what I'm saying. It's just like, because people don't look for it. People don't actually look for it. And it's so crucial, because it shows you exactly how far the patient wants you to go.
Yeah.
Because obviously it's always sustainability of life in one hand and comfort in the other. And you need to find their balance in between, wherever that lies. Some people just want to go smoothly. Some people will be like, do anything you need to keep me alive. I do not care. Do whatever you have to.
And that's one other thing, actually, one of the talks that we had from GMC was exactly on anticipatory care planning, and I think they did that because of COVID, and maybe they normally do as well, but it seemed like they were doing it for the first time because of COVID, and they were just saying you need to sit down with your patients early in their care and have a chat with them. How far do they want to be taken? Do they want to go to ICU? Simply ask them, would you like to be intubated or not if you get unwell? And they'll tell you.
Yeah.
And that's we've And we've asked that to some of the patients, and they've said well, and we've like, oh God.
Absolutely, honestly, it's a difficult, it's just difficult ground to stand on. But I think, yeah, it's about being able to have that conversation with them in the smoothest way possible. Because this is the thing, like, if you look at when the good medical practice has always been there. It's been there since 2001 or two, or like even long before that. But the most recent version is 2016, and that's because of the Gilligan case. In terms of those two massive cases where the two people sued the trusts they were in, or their family was dealing with, and it was mainly because it wasn't because of the decision the doctors made to make a DNA CPR or do whatever. It was because of the lack of communication with the patient or with their family. Like they were.
I remember this one. Yeah. This was the patient that was taken to ICU and then back.
Yeah. Basically, I think I can't remember the details of the name specifically, but essentially what it was is I think the doctors issued a DNA CPR at that point. They assessed the situation. They were like, okay, we can't really do anything for this person at this point. And this was like at the middle of the night or something like this, and it wasn't communicated to the patient. It wasn't communicated to the patient's family. The doctors pretty much made the decision by themselves, and I think the next day the patient passed away. And when the family found out how this came through, like they went to court. They actually lost the case, and it was appeal after appeal after appeal until they actually won. And then the law literally changed after this in terms of patients having more say in their healthcare and in DNA CPRs. So the only time you cannot discuss it with the patient now is if you know it will actually cause them psychological or physical harm in some way. And you really have to be very stringent. Otherwise, there's no way of avoiding that conversation because it's inconvenient. It doesn't matter if it's 3 in the morning or whatever it is. If you need to make that decision, you need to contact the patient. You need to try and do your best to have a discussion with them. Like you said, maximize capacity and obviously reach out to the family. If you reach out to the family and they don't get back to you, or if they don't know what to say, that's fine, because all you have to write is reached out to close family members, didn't really have an opinion on it, and they said just do whatever you can, or don't do whatever you don't.
Yeah, absolutely. So I'll give you another example. We had a lecture on stroke, and it was specifically based on anticipatory care. And I think the plan was basically a patient comes in. One of the most important decisions that you need to make is assess the patient and decide the anticipatory care, and do we want a DNA CPR form in place or not? Those two things. They should happen as soon as the patient arrives on the ward, or even in AU2, because that tells you where you're going, right? That really defines it. Are you going all the way to the ICU or not? Are you going to go all the way to resuscitate this patient or not? And all of that's based on how well this patient is, isn't it? So, and that again is not a decision that you make on your own. You make it with the rest of the team, and you make it with the family. You tell the patient if you're able to, or they're able to understand you. And if you've not spoken to either, or haven't made attempts to speak to the patient or the family, then you should have a valid reason why you should not have done either of those.
Absolutely.
It's really hard to explain why you haven't done or tried to do both. And so like one of the scenarios, the patient needed, she's dying basically after a stroke, and we've got an NG tube in place, and it's come out, and I'm trying to decide, do I put one in again or not? I want to put one in because it's like I'm more of that guy. Let's do things. Like we'll keep them live. But I decided to speak to the family and the daughter, and she said, no, you know what, my mom would not want that. My mom wouldn't want it. And we're like, we don't think she's going to do well. It's just a matter of just trying to keep her alive now. And she was like, no. The thing was, the daughter actually had a power of attorney in that case. It was a shared power of attorney. So it makes it, we have to listen to her. But see, even if she didn't have a power of attorney, and we as doctors think that she wasn't going to make progress, and the NG tube had come out, and she had said, my mum doesn't want this, that would be enough for me to say, I'm not going to put one more in.
I think this is the thing. You really have to put your own opinion and ego behind you. Like, it doesn't mean anything in the first place, and it just genuinely doesn't matter, nor should you try and make it, because it's like in that situation, like for someone to say no, like not only would that not make sense to me, it would actively piss me off. You know, but this is the thing, you have to try and look at things from other people's perspective and try and understand it. And I think when you do that, you're doing yourself a favor.
Yeah.
But because in the essence of it, what they say you have to do anyways, you understanding it will make you do it better. And allow you to be at peace with it. Okay, Mohsin, just before Dr. Mohammed, just before we finish off, I'm just going to hit you with some quick fire questions, because I think some questions are still on the table. So one of the questions, first of all, I'm going to start with mine. Which one is Scottish, Gaelic or phrases? I didn't know one was Scottish and one was English.
I cannot remember off the top of my head now.
I searched that one out. I had no idea. Okay.
Yeah. What was the other question?
Someone asked, anonymous asked, if a minor has a terminal illness and his or her parents tell you not to tell the minor, what would you do?
Looking into children's capacity, etc. So a child does not legally, they don't have capacity until that particular age, until they're an adult, whatever that age may be in the UK. So 16 versus 18. I think it's 18 is the adult age. So they don't have capacity. The patient's parent carries the decision making. And beyond that, if you disagree with the parent, then you can take them to court, or they can take you to court, for vice versa. So the question was that the parent doesn't want the child to know what is wrong with them.
I mean, the only thing I've seen so far is the doctor will always, because I've heard some of these situations, and what the doctor usually tries and do is they give guidance and counseling to the parents in terms of how you make your child understand what it is they have.
Yeah. So I think you will definitely need to get, if it's like a cancer diagnosis, you wouldn't just walk in and tell the child. It's very different from adults, and I don't know what the protocol is in the hospitals here. I've not done pediatrics, and I think it may be that you have to get the cancer nurses, the psychologists, and allow them to be present and do what they do better.
Yeah, absolutely. I think in this situation, it's not just your decision to make. I think end of the day, does the patient, despite having a minor, have a right to know if they have a terminal illness? I think so. Yeah, definitely. How you get that news to them is something that's very icky, sticky, and complicated.
I think this question arises from parents' concerns than anything else. The parents being protective of the child than anything else. They're just trying to look out for them and don't want psychological trauma, and they just want to be assured that you're going to do it in a way, the best way possible.
Another question, I've been trying to figure this out since the start of the Q&A. I don't know if I'm reading it wrong. How can a doctor protect himself in the future from any oral consent from a patient? Somebody else, Taylor, said about the first situation about the child, if the doctor had asked the question, I will be examining this area of the child, would that be okay? Wouldn't that have avoided the issue entirely?
I think he had. Yeah. He absolutely, he wouldn't have gone in, just randomly pick up the baby and start doing it. No, he definitely had. Yeah. It was just a matter of how the mother saw it, I think, than anything else in the room.
Yeah, it all comes down to perspective in that sense, doesn't it?
Yeah.
The other thing I wanted to ask, just your personal opinion on, is realistic medicine something you guys get taught? So like the 5 different foundations of realistic medicine and like waste and product and from extracurricular studying, right? So I learned all this stuff from extracurricular study because in my head I have the conceptualization of you guys are sitting there getting taught this and I need to catch up.
I might have taught realistic medicine, but
Yeah.
if I see the 5,
I'm sure you covered it somewhere. It's probably just like, you know,
Yeah.
once you become a doctor, it's just like everything's gone.
Yeah.
You remember what you need to remember.
Yeah.
Like when you're enthusiastic medical student, everything sticks. But like, yeah, no, it goes relatively quickly. But it's super, super interesting concepts. It goes over here like medicine. This I've never seen this such a thing as. I mean, the only person who really decides in a lot of these countries if you live if they do CPR on you or not is the doctors.
Right.
You know, like the patient has very, very, very little say in it. But ironically enough, like, you know, even if for the sake of convenience, what really surprises me, because I mean, in my opinion, like in my head, before I knew what DNA CPRs were, in my head, every single patient that was having a cardiac arrest was somebody you'd have to do CPR on. I literally thought that was half the job, which in reality, a lot of people don't even want it.
Yeah. No. True.
And that still doesn't make sense to me personally because I'm just like, why would you not want it? But then again, it's just everybody has those different beliefs, and it's just um, accept them and understand them. And I think more important than that, and this is really just sort of gems of wisdom for everyone else, is understand the idea that you need to follow them through for your patient if you understand them or not, or if you respect them or not. Like it's your job.
Yeah, no, absolutely. And I think in terms of speaking, again, you know, anticipating care planning, kind of asking them about DNA CPR at the same time, both should be done at the same time, is my opinion. The 2 questions that can really help you get started with DNA CPR discussion is, 1, have you spoken to somebody about it, or have you discussed, you know, do you want to discuss it, is ultimately the underlying question you're asking. Have you discussed this before? Would it be okay if I discuss it today, considering that you are ill or not doing well, or I'm concerned that you're not doing well and I want to discuss it, would it be okay? And if they say, no, I don't want to discuss it today, then you just stop. And then it would really, if they were to deteriorate further, I think it would be wise to contact the family and speak to them. That the patient doesn't want to discuss it. It's a difficult one, because if a patient has capacity and they don't want to discuss it,
like, what do?
You can't really speak to them. You can't really.
Exactly the thing. This was exactly the thing. I remember like watching a lecture about this with the Royal College of Physicians and Surgeons, Glasgow, and they were discussing. I think it was a guest lecturer that came on, and he was like, "Hands up if you have a will," you know. And then so many people say like, "Hands up if you plan your funeral," you know. Hands up if you know how you want to die. Hands up if you know how far you people want to go. And then they did like all these different studies in terms of why people avoid these things, why people avoid dealing with death, even long before this happened. And I think a couple of things. One, like they're either not considering it at all, or it's just too anxiety provoking. It's so anxiety provoking because you're sitting there and like you're talking about death in the most intimate way you can with it. You know, it's like, okay, do not try and save my life, or try and save my life, and like, you know, it's just that constant reminder that that might be around the corner.
Yeah.
So it's like I can understand, but how would you overcome that? Like,
I think it would be a good idea to get a family member involved, despite the fact that the patient has capacity, because you're not breaking confidentiality in any way. All you're saying is that I'm concerned about your mum. I would like to discuss DNA CPR with her. She doesn't want me to. Maximizing capacity. Yeah, maybe.
if the patient doesn't have any family and they refuse to discuss it, but they're in capacity, I think that's a decision for that the doctor can make ultimately, right?
It's a medical decision, yes.
Yeah. I think that's the other thing as well. Like when they do give you the reasons and everything, especially when you're dealing with anticipatory care plans, just remember clinical judgment is like a huge part of it. I feel like a lot of people forget that, because I know we're always like, listen to the patient, listen to the patient, listen to the patient. Listen to the patient. You don't have to do what they say. Make sure they're
the patient cannot demand CPR.
yeah.
He cannot demand.
Which is what baffles a lot of people.
Yeah.
That's so confusing for us.
So you have to look at both sides, right, to make sense of it. A patient cannot demand any treatment. Ultimately, it's you as a professional doing the right thing in the best interest of the patient have to make the decision on. If the patient disagrees, then there's complications. You have to go to your medical union and get advice and maybe taken to court, blah blah blah. So we had a patient in stroke who we were like, DNA for CPR just because of stroke, and then he got an infection, COVID, and we're like, okay, DNA CPR. But family were like, no, patients for CPR. The consultant that night had to get some sort of order from some higher authority to say that this patient's not for CPR, because there was a direct conflict between the doctor, the consultant's decision, and the family's decision. And there was no, I'm not sure if there was a DNA power of attorney. I'm not sure if there was power of attorney or not. I'm not sure.
The patient didn't have capacity, right?
A patient didn't have capacity, no.
See, that's tough, because I mean, like, it's so common, isn't it? It's like a lot of the times, like, your doctor will tell you something you disagree with, and you're like, if it's minor, it's minor. You're like, chalo, okay, cool.
Yeah. Oh, you don't want to give me blood.
When it's somebody's life, when it's like, when you talk about CPR, like all of a sudden, like, stuff gets real. So like, it's just very hard to understand things from that perspective. But Dr. Mohsin Mohammed, I really want to thank you for your time.
I'm sorry if I overran.
No, I think we're actually just on par. Perfect timing. And I think this is probably one of the more interesting webinars I have. I have like so many every month, so this was definitely probably the most fun. So I really want to thank you for that. Guys, again, please do fill in the feedback forms. I have sent the link for it. You should be able to see it in the Q&A. And again, I want to give a big thank you to Dr. Mohammed for coming along and talking about medical ethics. And I think it was really great and really enlightening in terms of all the different aspects we can go on, we can research. Again, when you do fill in the feedback forms, not only will you get a certificate for attendance, but you will also get a copy of the good medical practice sent out to you, just so you have it handy. And that's something, like Dr. Mohammed said, definitely worth going through. I also want to thank you, our sponsors, Lectorio, and a big thank you to them. You will get a 50% discount code sent out to you. I think we have like a little raffle thing where we're giving out like a 6-month pass as well. And that will be great fun. You'll see that on the feedback form. Again, thank you so much.
No worries.
Great. I'm just going to leave this call open so people can access it, but I think we're good to go.